Good afternoon, guys. Can you all hear me? Can I just get like a quick indication in the chat box? That would be perfect. Okay, great stuff. Okay, so I'm just going to start. I'm sure you guys can hear me. Okay, so good afternoon, guys, and welcome to our first lecture, or our first lecture. Oh, okay, thank you so much. Okay, great stuff. Good afternoon, and welcome to our first PSSS lecture for the year 2022. And in this lecture is surrounding the basics of general surgery. So just one or two important things. Well, firstly, my name is Wits, and I'm the chair of our lecture series committee. So just one or two important things before we get started. So we're going to take all of the questions at the end. So throughout the lecture, just type your question in the chat box, and then I'll ask them directly to Dr. van der Schyff at the end. Then right at the end of the lecture, we're also going to send a link for a Google form, which is just a very short feedback form, but it's also done to basically record our attendance of the lecture series session for if we need it later on. The other important thing is also that if you fill in this Google form, we're going to have a lucky draw, and then you have the chance to win a scrub cap, which is very exciting. So yeah, please remember to fill in that form. Then can I also just please ask that everybody mute themselves, and also just turn off your camera for the series of the lecture, and then right at the end, if there's time, you can unmute yourself for a question, but just raise your hand before you do that, please. Okay, then I'm just going to introduce Dr. Francisca van der Schyff, which is our presenter for the session. So Dr. van der Schyff completed her MBChB degree at the University of Cape Town, and then she also obtained her specialist surgery qualifications at our very own University of Pretoria, both of them cum laude. She was accepted as a fellow in the European Board of Surgery in Transplant Surgery after completing her abdominal surgery fellowship. She is currently active in liver and kidney transplantation from both cadaveric and live donors at the Wits Donald Gordon Medical Centers in Parktown. So without further ado, I would now like to give over to Dr. van der Schyff. Thank you, Doctor.
Afternoon, everyone. If you can't hear me, please let me know and we'll fix it. Thank you so much for the opportunity. It's a real pleasure to be here, and hopefully I can give you a short introduction into what general surgery is all about. And sorry, let me just check what's going on here. Okay, let me just find my slides. There we go. Good. Can everyone see that? Alicia, are you happy?
Yes, thank you, Doctor. We can see it clearly.
Right. And is the slide maximized now?
Yes, it is, Doctor.
Okay, great. So I'm, like Alicia said, I'm Fran, Dr. Fran, as patients know me. I'm one of the transplant surgeons at the Wits Donald Gordon Medical Center, and I am locally born and bred. Spent some time at UCT to do the primary degree, and then came back to Pretoria, where I was born to do general surgery. Spent another 2 years in pediatric surgery, and then finally made the jump to transplant surgery, where I did an abdominal transplant fellowship, which is another 2 to 3 years. And I've been on the permanent consultant staff for the last 2 years. So let's start off with the basics. What is surgery? In its simplest sense, surgery is a procedure that involves cutting a patient's tissues or closing a previously sustained wound. Pretty basic. Or it's defined as the treatment of injuries, manipulation. So a very proactive approach to disease and disability. What's important to note here is when you treat a patient and when you operate on them, you really do quite an invasive procedure. And in any other setting, other than surgery or in any other medical field where you expose and examine a patient, that would be considered assault. And therefore, obtaining full consent from the patient and building a trust-based relationship between the surgeon and the patient, or the doctor and the patient, is critical. That patient is really in a vulnerable position when they come to see you. So always bear that in mind, that what you're doing to the patient really wouldn't fly in any other workplace situation. So always treat the patient with respect and obtain consent. So why do we need to perform surgery? Well, this guy, he was Ambroise Paré. He was a 16th century French military surgeon, and he defined the need for surgery as having a place in 5 situations. Firstly, to eliminate that which is superfluous, cut off what is not required. Secondly, restore that which has been dislocated. In other words, put things that are hanging out back to where they belong. Or separate that which has been united, or join that which has been divided, or repair the defects of nature, in other words, congenital defects. And that's a pretty accurate summary of what we do in surgery. And it's still quite relevant today. But there's been some serious barriers to the development of surgery as a viable treatment modality. And surgeons were really considered to be the butchers, the ruffians of medicine until very recently. And the reason for that is that we had 3 issues that were very difficult to control up until the modern era. And patients have required surgery, obviously, since the dawn of man, but we have not had these 3 building blocks in place to provide surgery in a controlled manner that would ensure survival. And it was really kind of a Hail Mary, chop the leg off in the battlefield kind of intervention until very recently. And the first issue was pain. How do you do what you need to do to a patient with the patient tolerating it and surviving the physiological insult of major surgery? And it was really only at the advent of modern anesthesia and specifically mechanical ventilation, positive pressure ventilation, that we could control the operative environment and allow us to do complicated surgery. Secondly was the problem of bleeding. When you cut, you bleed. Patient bleeds and you bleed. But essentially, doing complicated surgery was not possible before we had energy devices or good surgical technique, good suturing materials, and then hematology came around and developed to provide us with blood products and to allow transfusions, especially in the trauma setting or major surgery setting. And then thirdly, the biggest killer of all was sepsis. And infection was a massive risk, even for minor injuries. In the First World War, many soldiers died from infection, from relatively minor flesh wounds. And it was with the advent of modern antimicrobials, including the antivirals, antifungals, and a broad range of antibiotics, including those that cover the multi-drug-resistant organisms, that has allowed us to operate on patients, and then sterile technique. It really was a modern addition to the field that one should wash your hands before operating on a patient. Remember, there were no gloves, masks, modern sterile gear as we know it now. Doctors would touch any sort of infected wound and then deliver a baby straight after, and couldn't understand why these women were dying. So sterile technique and antimicrobials has really allowed us to move forward, and it's been advances in this field that has allowed surgery to move from kind of a sketchy art to a scientific discipline capable of treating many of the diseases and conditions. Sorry, am I still on? Alicia?
Yes, Doctor.
Okay, great. Sorry, I pressed the button. An example of this development was when you consider liver surgery, and I gave you a picture there. Now, I'm a liver surgeon, also a kidney one, but I've got a soft spot for the liver. And if you consider what Longmire said, and he said that the liver is a hostile organ, and it's to be avoided, because it welcomes malignant cells and sepsis so warmly. It bleeds so copiously, and it's often the first organ to be injured in blunt abdominal trauma. But as science developed and as we moved forward, we understood the anatomy better. You can see there that the segments and the divisions and the anatomical divisions and inflows and outflows of the liver have been defined. And we are now performing complicated liver with very low mortality rates. And that's kind of always a case in point to me of how far we've come over the last 150 years. So what is general surgery specifically? According to the American College of Surgeons, it's a discipline of surgery with a central core knowledge around, firstly, anatomy. Right, so you can see those pictures there. You cannot operate on a patient in that area without knowing exactly what runs where and what to expect. You need to have a firm grasp of physiology and metabolism. Doing a perfect operation and not understanding what the patient would endure and how they would recover afterwards would be futile. So physiology and metabolism is crucial. Immunology, and the influence of understanding our immunological system. And you also need to know a little bit about immunology. Nutrition is crucial. And then obviously pathology, wound healing, shock and resuscitation. You need to know something about the critically ill patient and what happens in an intensive care unit. And then core knowledge around cancer. That is a big bulk of the work that a general surgeon does is around neoplasia. So a general surgeon is one who has specialized knowledge and experience related to the diagnosis, pre-operative and post-operatively, including the management of complications. Now it's important to note in that sentence, you must look after your patient pre-operatively. You're not someone who will receive the patient neatly wrapped up for you in theatre to fix and do the fun parts of the surgery. Pre-operative management, optimizing your patient is crucial. Obviously, operatively, you must know how to operate. And then post-operatively, looking after your patient diligently afterwards to ensure good outcomes. And then complications. Don't do something unless you can handle your own complications or have a friend who can, someone to call if you run into trouble. So what is the scope of general surgery? It's a very broad field. It's important to remember that in the beginning there were only surgeons and non-surgeons. All the subspecialties developed later on as the field grew so large that you could not possibly have a grasp on every field and people branched off. But general surgery is a broad field. It includes abdominal surgery. The liver, pancreas, diaphragm, small bowel, large bowel, and kidney belongs to us. We do share the kidney a little bit with the urologist, but certainly in transplantation, most transplant surgeons are general surgeons. However, there are urologists who transplant kidneys. The breast, skin, and soft tissue generally are handled by general surgeons, except for reconstruction or very complicated wounds where the plastic surgeons would come and help. The head and neck, complicated area, you need to be competent in handling trauma, the vasculature of the neck, the endocrine organs, in other words the thyroid and the parathyroid, and in the congenital and oncological disorders, often in conjunction with other specialists such as maxillofacial surgeons and plastic surgeons. Then the vascular system, that is where vascular surgery has developed as a subspecialty, and here we exclude the intracranial vessels, those belong to the neurosurgeons, and then the heart, belonging to the thoracic surgeons. The endocrine system is also ours: thyroid, parathyroid, adrenal, and the endocrine pancreas. Remember, the pancreas is both an endocrine and an exocrine organ. And then surgical oncology. Except for gynecological malignancies, the bulk of it would be handled by the general surgeon. Trauma, the surgeon is in charge of the multidisciplinary team that is required to look after a trauma patient. You will steer that ship and you're in charge of the trauma patient. So comprehensively managing trauma is very important. And then the critically ill patient with an underlying surgical problem. It's important that you're involved in the complete care of the critically ill patient, both in the emergency room as well as in the intensive care unit and trauma or burns unit. Now, how do we classify operations? We classify them according to urgency, risk, and purpose. So in terms of urgency, you could call them elective, urgent, or emergent. An elective procedure, as I know most of you know, is a pre-planned procedure that suits the patient and the facility, and you can wait indefinitely, and nothing bad will happen to the patient. Those are lumps and bumps, cosmetic procedures, and so forth. An urgent procedure is something that has to be performed in a relatively short time frame to prevent or avoid a poor outcome. In other words, you'd better get on with it soon, within a day or two, preferably soonish, without putting undue pressure on the system. In other words, you're not going to crash someone's list because this patient's dying, but you need to get into theatre within the next couple of hours. So that would be patients with appendicitis or patients requiring an amputation. And then an emergency surgery are obviously those that you must do immediately to save the patient's life. In other words, the bleeding patient, patients with necrotic bowel or necrotic limbs that must come off, or patient with bowel obstruction, in order to save a life. And it's often in this sort of scenario where surgeons are considered a bit brash and aggressive because, you need that willingness to fight for your patient. The emergency list is always booked full of patients from all sorts of disciplines, and everyone considers their case to be important, and you will have to argue your case about why you need to go first. In risk, you get major surgery and minor surgery. Major surgery are those that requires hospitalization and specialized care. It carries a higher degree of risk. It involves major organs and or life-threatening situations. So some people say there's no such thing as minor surgery, that all surgery carries risk, and I tend to agree with that, but there are those things that you can do as in a day case basis, circumcisions, simple hernia repairs, lumps and bumps sort of thing, with low risk of complication, and those are mostly elective. What you see there at the bottom, I said elective surgery is better than emergency surgery. There are conditions which will develop over time if left neglected, which will turn into emergency surgery. So rather be proactive and manage your patient proactively from the beginning. Now, what about purpose? Which types of procedures are done based on purpose? You get diagnostic procedures, and that's when we biopsy lesions, we do bronchoscopy, endoscopy, and that's purely not to intervene, but to diagnose. Then you do ablative surgery, and that's when a diseased body part is removed, like a mastectomy or an amputation. And then you get reconstructive surgery, and that is when you restore function and form to improve health concept. For example, tissue flaps for patients that lost a large amount of soft tissue coverage for complicated fractures and so forth, or burns, or breast reconstruction after surgery for a malignancy, and then cosmetic procedures would be included under reconstructive. Constructive surgery is when you repair or you form a structure that was malformed at birth, and that would include the congenital defects such as a cleft lip repair, cardiac defect surgery, esophageal atresia, duodenal atresia, that sort of thing. Of course, we have to include transplantation as a whole separate field, and that is obviously when we replace either a solid organ or a hematological cell line, such as stem cell transplantation, which are diseased. And then last but not least, palliative surgery. So that is a non-curative procedure with the intent of reducing the intensity of illness or to relieve suffering and make patients more comfortable for end-of-life management. And that could include nerve ablation or bowel diversion for a patient with advanced colonic malignancy, for example, to relieve the pain and suffering of a bowel obstruction when there's nothing else to offer the patient. So, all of us want to do successful operations. Presumably that is your aim when you look after a surgical patient. So what do you need to perform a successful operation? First and foremost, you need the correct patient. Now that may seem obvious, but your patient that you've selected for a specific procedure needs to be fit for the procedure intended. Okay? Is your patient fit to withstand the procedure that you've got in mind? Are they consented fully? Do they understand what you would like to do for them, and what are the potential complications? Get someone in to help you with the language barrier if that is a problem. Remember, children also play an active role in decision making. there is such a thing as assent in children. That implies that the consent will be given by a competent adult who's in charge of the child, so to speak, but asking the child or informing the child and explaining to them what is going to happen or what is next is very important. Having a cooperative child, at least who is somewhat willing to go along will make a big difference, and you need the correct indication. Be very sure what you're doing and what for. You need the correct timing. Is your patient fit right now? Can you improve them? Some patients are very malnourished. Some patients have got severe electrolyte abnormalities. Some patients need to be transfused. Listen to your anaesthetist. If there's time, rather get your patient into better shape. They will do far better post-operatively. And do you have the optimized theatre and staff? Do you have staff with the correct level of training? Do you have all the equipment that you need? There's no use plunging into a very complicated procedure without having the instruments. And certainly in transplantation, there are a select number of anaesthetists that we work with who are specifically have got experience in liver transplantation before we proceed. And then last but not least, the correct surgeon. Are you adequately trained? Do you need to ask for help? Is there someone better who can do this operation for the patient? Do you have help if you need it? And can you handle your own complications? So as we said there, a good surgeon knows how to operate. A better surgeon knows when to operate. And the best surgeon knows when not to operate. Or the last there at the bottom, this quote of a good surgeon knows when to operate, a better surgeon knows when not to operate, and the best surgeon knows the limit of his operability in inoperable cases. And that's very important to honour your limits. So, a saying in surgery is, if in doubt, cut it out. But when should you not operate? Absolute contraindications. A moribund patient. Obviously, you've got to ask yourself, what am I trying to achieve here? I'm not talking about the patient in hemorrhagic shock that you will do a resuscitative procedure on. That's different. But obviously, a patient that's clearly agonal is not a fit patient. Does the patient have cardiorespiratory compromise that is prohibitive to your anesthesia? Will you kill the patient on the table, essentially, from an anesthetic perspective? That patient may not be fit for any intervention. Does the patient have severe metabolic or hemostatic imbalance? Are you operating on a patient with DIC? Or someone that will never clot, no matter what you do? Or do you have a patient that's going to arrest on induction because they've got hyperkalemia or hyponatremia? And if there's time, you have to correct those things before you proceed. And then obviously, lack of informed consent. That's a typo, in life-threatening cases, you can override informed consent if there's no one available to give it by the superintendent of the hospital. Relative contraindications, age. Now that very rarely plays a role anymore. We operate on very premature children as well as the very, very elderly. Pregnancy is something to consider. Remember that the fetus and in different trimesters will be in different states of development, and some would recommend not operating on patients for certain things in certain trimesters. Obviously, there will be indications where you will have to intervene. Comorbidities, in-stage incurable disease. If you do that patient no service unless you're going to palliate them and offer them relief of suffering. So don't operate just for the sake of it. Then better alternative therapies. Be a big enough person to accept that some people can offer your patient better alternative therapies other than surgery, if that is the case, and allow that patient that route, that avenue of therapy. And then technical issues. If you don't have the right equipment, you are in for a world of hurt if things go wrong in theatre. So get that fixed before you go. So the surgeon's job is far beyond manual abilities. You need, like I've mentioned, theoretical knowledge of all possible treatment options, especially non-surgical ones. You need to always assess risk versus benefit. Is the ratio in favor of benefit as opposed to risk? Then you need practical knowledge. Surgery is a practical specialty. You need the hands to do it. You need experience, and that comes over many, many years of practice and training, and honour your limits. You need to know your patient. Take a proper history, examine them, recheck special investigations. Never operate on a patient you have not reviewed and examined yourself. That is a common mistake that will land you in hot water. See that patient, review every result yourself, and the informed consent. And then, importantly, audition your result. Many units never do this, especially in private practice. People do not look at their own morbidity and mortality, and the South African health service environment is very unregulated. Many people do just whatever they like out there and is never held to account. And whether it was the correct procedure, what are your outcomes? Do you have acceptable outcomes of mortality and morbidity? So do your own M&M, do your team's morbidity and mortality, preferably in a public forum where you can get input and to learn, to be able to learn from your mistakes. Publish your unit's outcomes. So I work in a transplant team where we've got many specialists involved, and we've got 5 surgeons who all operate on patients at different times. And for us, it's very important to publish our outcomes every second year internationally on survival and outcomes, and that allows you to learn. So remember, we will all hurt patients. That's a very unfortunate reality of being in medicine. All of us will make mistakes, and you will hurt a patient. But not learning from it is the ultimate disservice. So be honest with yourself and look at your outcomes. Not to self-flagellate, but to go back, ask a senior and mentor for advice. What should I have done differently to have a better outcome for the next patient? And I like this quote by Norman Schwarzkopf. He says, the more you sweat in peace, the less you bleed in war. So it's all about preparation. Know your patient, know your theory, know how to do the operation, and learn from your mistakes. So what is general surgery not? Right, we all know the stereotypes. The stereotype of the surgeon is being egotistical, arrogant, generally males, masochistic, confident, scary. Those things are certainly true to an extent. I guess stereotypes are there for a reason, but the specialty has moved forward from that sort of picture a long time ago. And unfortunately, general surgery is not Grey's Anatomy. We do not have time for the kind of blowouts that they do, and certainly our colleagues are not as good looking as we would like. So you will realize that very soon when you're in the field, that there's a lot of misconceptions out there. But it can be a lot of fun. So let's talk about the surgical specialties. What are the different subunits of surgery? So as I've mentioned before, in the beginning there was only general surgery, surgeons and non-surgeons. And essentially people started branching off into independent specialties, and specifically cardiothoracic surgeons have branched off completely, and we do a separate training program for them now, as well as pediatric surgery. That is not a fellowship or a super specialty of general surgery anymore. They are independent disciplines, and we train primarily in that discipline. Many people start off with some training in general surgery, which is always a good idea. Never time wasted to train in general surgery before you move on to something else. But essentially, they are now independent specialties. What are the super specialties or the subspecialties of general surgery? So trauma is a subspecialty that you can go and do after general surgery to become a trauma surgeon, and often there you combine trauma surgery with critical care. Then you can do surgical oncology, focusing on breast and endocrine, and that overlaps a little bit with hepatobiliary surgery, HBB. HBB is a subspecialty as well. Then the transplant is a subspecialty as well, requiring extra training, as well as colorectal surgery, vascular surgery, bariatric surgery, and minimally invasive surgery, MIS. So all of those are potential career pathways for the general surgeon. So how do you become a general surgeon? Blood, sweat, and tears. Indeed. Obviously, you need to finish your MBChB 5 to 6 years. Internship, community service, 3 years. Medical officer post, if you're lucky, 1 to 3 years. Some people do manage to find a training post immediately after community service, but that's becoming more and more uncommon as the demand for specialist training increases. Then you need to enter a training registrar post. That needs to be affiliated with a university, with a medical school, and you need a training number. And that will take you at least 4 to 5 years. For many, it will take longer. Within that time, you need to do 3 sets of exams. You need to complete a logbook filled with specific requirements and a research dissertation. And then you can, if you wish, choose to do a subspecialty, and that will take you another 2 to 3 years. And that is, after all of that, you are at the beginning of the road. That is not the end. That is the start of a lifetime of learning. And preferably, you should always stay close to a mentor, a senior that has been there, done that, who can help you and guide you and help you learn throughout your lifetime and throughout your career. So, what are the career pathways for a general surgeon? You can do general surgery in state practice. There are many units in our country who need a good general surgeon to alleviate a whole lot of burden of pathology and disease. And there certainly are those posts available, challenging as they may be with a resource-constrained environment. You can be a general surgeon in private practice, and that is certainly an option that many people explore. You can be a subspecialist in either state or private practice, or you can be a subspecialist within an academic firm or partnership where you are affiliated with a university but you're working private. And it's an unusual situation to be fortunate enough to be in that sort of scenario, but that is an example of where I work, where we are an academic partnership of surgeons affiliated with a university within the transplant unit. And we work together as subspecialists, and we offer treatment to both state patients and private patients. So, let's get back to you. What does a student and an intern need to know about general surgery? Just some general tips and tricks, things to look out for to make your life easier as you go through this convoluted road of becoming a clinician, and some of you surgeons. I include the intern because many of you will be interns within the blink of an eye. So I'll give you some general guidelines on general conduct, emergency room conduct, how to behave in theatre, what to expect, and in the ward after care. Generally, please remember, every patient who comes to you is in a bad place. It's never good news when you come to a hospital. And that patient is in a vulnerable, frightening situation. Always bear that in mind. Establishing a trust relationship with the family and the patient is critical. And that is, you establish trust by being competent, by being available when you are needed, and by being a good communicator. That patient is your responsibility from the moment they present to you until discharge. And often thereafter, often patients will come back to you over and over again, and they remain with you in a partnership for many years afterwards. And that's a responsibility that you will have to be. Things that should not need mentioning, but I do mention it because I see it often in very junior colleagues. And please make a note somewhere in your mind that your dress and personal hygiene should reflect the respect you have for the patient. You might be a chill dude who likes wearing slacks and a t-shirt on your days off. That is not appropriate when treating a sick patient. You wouldn't want your mother to be treated by a surgeon that presents sloppy and unkempt. Watch your language around overhearing patients. We all tell crude jokes. We love horsing around with our colleagues, and that's what makes medicine fun. Often our humor is dark and inappropriate. But beware if there are patients around in the emergency unit, in casualties, and in a patient that is still awake in theatre. So just watch yourself in terms of what is said out loud. Check and recheck your patient throughout your treatment plan. If you've initiated a treatment plan, it's your responsibility to check that what you've prescribed is working. Otherwise, it's pointless. And if it's not working, change the plan. And then lastly, that patient who irritates you the most in casualties or in the ward is in most danger of having something missed. That is the drunk, belligerent, difficult patient that really annoys you. Watch out. That is the patient that is hypoxic, that's got a traumatic brain injury, that is shocked, that you were avoiding, and they can catch you out badly. So, what happens, how should you conduct yourself in the emergency unit? Basics first, before anything else. You have to know how to recognize the shocked patient. Okay. No shock, all its forms, and what your initial step should be. That is life-saving stuff. Don't take a long history and examine each patient when you're dealing with a shocked patient. Look at your patient. Is the patient shocked? Okay. And start resuscitation in parallel to other activities. Shock is telling you that the patient's physiological reserves are overwhelmed and that will be if you don't. Okay, so always cover your basics. Airway, breathing, circulation, the usual ABCs. Okay, then you won't be caught up. Obviously, if the patient's just chilling there, having a nice chat to his neighbour, you're not going to worry about the ABCs, but always start there, just for yourself. Always wear protective gear against blood, secretions, and radiation. You must protect yourself. Don't touch a patient without gloves. Don't go to the operating theatre without eye protection. Don't stand in the way of the X-ray machine. You might think a once-off X-ray is not going to do you much, but over a 30, 40-year career, you're going to end up with a malignancy of your thyroid or a radiation impact on your bones. So look after yourself from the beginning, always. Then you can go to a history. Take a good history. Focus on previous surgical complaints, previous surgeries. What are the comorbidities that's going to elevate risk for this patient? Is your patient diabetic, hypertensive, or a cardiac patient? Those present to you specific anesthetic risks which will alter your management plan. Examine your patient properly. Each patient that comes offers you the privilege to learn from them, from their illness, and harness every opportunity to hone your clinical skills. You may not see that picture again for a long time to come. So examine patients. I'm not saying you need to do a rectal and vaginal exam on every patient who presents to you, but examine the problem with attention and verify your findings with a senior who can guide you and say, no, did you see this? Did you see this? And then lastly, make good notes. It will protect you in future. All medical notes are legal documents. If it is not recorded, it was not done. So please write down what you do and record any communication with other specialties properly with dates and times. So those are general guidelines to protect you in the future. Right, let's talk about theatre. What happens in theatre? How do you prepare a theatre? Okay, before you can start an operation, and you as a student and as an intern in community service, a registrar, even as a consultant, will be involved in all of these steps. So knowing what would happen and what is expected will help you kind of find your feet. Before you start a new case, you will see the staff removing all used instrument sets and anesthetic disposables that have been used for the previous patient, including the light handles. Okay, light handles needs to be sterilized in between each case. The bed, all trolley surfaces and the floor is mopped and cleaned in between cases, and feel very welcome to us to offer your assistance in doing that to get the next patient on the bed. New anesthetic drugs will be pulled up. You will fetch the correct surgical sets from CCSSD, and clean linen is placed on the bed. You then introduce yourself to the scrub nurse, the floor nurse, the anaesthetist, the anesthetic nurse, the perfusionist, the lab technician, and radiographers, whoever would be helping you with this case. You as the surgeon is in charge of theatre, and a successful operation depends on the team work of each of those team members. So introduce yourself, tell them who you are. I'm so-and-so, I'm assisting Dr. So-and-so today, so that we know who you are and what you're doing there. Then confirm that you've got the blood products that you would need, that you've got all your surgical instruments that are required, that are available and working. If you are the lead surgeon, run through the procedure with your anaesthetist. Just go through the plan. What is the plan with this patient? Are you planning on cross-clamping major vessels, which is going to cause major hemodynamic shifts on his or her side? What is your anticipated blood loss? Are we prepared for that kind of blood loss? Do we need a cell saver? Do you need single lung ventilation if you're going to open the chest and work on one side of the chest? Are you planning on opening the chest for whatever reason? And only then you can call for the patient or fetch the patient from ICU with the anaesthetist. So that is the prep of the theatre that you need to do before you even start. Now, the patient arrives in theatre. What do you do then? Confirm consent. Again, do your first surgical pause. One of the nursing staff will identify the patient. The doctors involved will be verbally identified, the procedure planned, allergies of the patient and antibiotics given. And that should be routine for all procedures all over the world. That's WHO the recommendation to allow for safe surgery. The patient is then transferred to the bed. Please remember to protect the patient's dignity. Okay, don't let their beds flap around with the door open for everyone to see. If your patient is weak or in pain, help the patient, roll the patient across. Don't expect them to wobble over to the bed if they cannot. And protect the patient's dignity. The anesthesia will then be administered. Help where you can, especially for things like you can offer, shall I put in an A line? Can I help you with the central venous line? Catheterize the patient yourself and pre-wash your operative site. Set your theatre lights in the correct position that you would prefer them to be in. Check that your instrument sets are correct and that the laparoscopic stacks, if you're going to do a laparoscopic procedure, are present and working. Before you scrub, do not touch any green sterile pads that are being opened by the staff. Be mindful of where your scrub nurse is working. Don't touch her and don't buzz around her. She's trying to prepare your surgical field for you. Remember, don't walk through the sterile trolleys on the right side of the theatre bed. That is the sterile zone where your scrub nurse will be working and cleaning the patient, draping the patient. Okay, until you scrub, try not to walk through that area. You might get shouted at by the scrub nurse. And then lastly, always empty your bladder and eat something before every case. You never know how long that case is going to be if things go wrong. And that's just a personal recommendation. Always to eat something before you start. Now, scrubbing. I'm sure most of you have scrubbed, and some of you have done it correctly. Others have been sent back to do it again. But scrubbing properly is very important. It really is very important. Firstly, check that your hair is covered. You shouldn't have any hair sticking out of your theatre cap. If you've got a lot of hair, use 2 theatre caps. Okay. Your face mask must be fitted. If you've got a huge beard, that beard cannot be in the operative field. Okay, it needs to be covered properly by 1 or more face masks. Your elbows need to be exposed. You cannot wear a top under your scrub. Top even in winter. It must come off and your elbows must be exposed. Remember to fit your surgical loops securely. That is the operative microscope that we use in transplant, if you use one, and attach your light source. Then open the taps. Don't make them boiling to burn. Once you burn your hands, you breach the epithelial barrier and that can be a sepsis risk. So just warm water. Keep your hands above your elbows at all times. The water should drip from your fingertips down to the elbow, not from the dirty elbow downwards. Dispense soap into one hand with the opposite elbow. Okay, and wash from the elbow to the wrist. Leave the soap on and repeat on the other side. Dispense soap and wash your hands now. Remember, there's soap now on your forearms. At least once with a brush under the nails. Don't scrub your hands raw with the brush. Once a day with the brush is enough to make sure that your nails are clean. Make sure you cover your wrists, your fingers, in between your fingers, your fingertips, the wet spaces in the back of the hands. Then you rinse from the fingertips down to the elbow. Then you dry each arm and hand from the fingertips down with a sterile tissue that will be in the pack with your sterile gown. Throw that towel away from the sterile trolley. Okay. Then unfold your sterile gown away from you, insert your arms and do not touch the outside of the gown. Okay, the outside is not sterile. Then you don each glove, making sure it covers the cuff of your gown fully. Don't let your forearms stick out. And the sister will then tie your gown at the back. You can hand the waist tie to her with the end with a detachable tag onto it. Once you scrubbed, I see a lot of the juniors actually kind of look unsure. They're now sterile, they don't know where to go. Walk purposefully to the left side of the bed once the scrub sister has finished draping and rest your hands on the patient. Okay, don't keep your hands in front of your face or then you're tempted to touch things that you shouldn't. So just walk to the bed, put your hands on the side of the bed with your body next to the bed so that no unsterile things will touch you. Right, so what are the common instruments that you may encounter on the trolley? You'll see that the scrub nurse has got a high trolley that stands at the foot of the bed, and there she will place the important instruments that will be in common use throughout the procedure. Now, these are just some basic instruments that we will use during a laparotomy. So starting at the top, you've got a curved clamp to hold up the abdominal wall. That's called a Morris. So you might get asked Morris. I mean, that is the thing that the nurse will give you. Don't help yourself from her trolley. Unless you want a smack from the scrub nurse, she will hand it to you. Just below that, you'll see there's another retractor, a smaller one, that is called a churning retractor. On the left, those big curved retractors are called devas, and they're often nice and bigger, deeper patients to retract the abdominal wall. On the left side of that, there are forceps. If a forceps is toothed, we call it a Gillies. If it's not toothed, we call it a tissue forceps or a DeBakey forceps. Don't grab delicate tissues with a toothed forceps. A toothed forceps is for skin only. Otherwise, you use a non-toothed forceps. Okay, especially when you work with arteries. On the right-hand side, those flat things are called copper malleables. They've been taken off many laparotomy sets now, but it's generally its intent is to keep bowel down as you close the abdominal wall. On the right side of that, there are needle holders. At the bottom, there are more clamps. A very small clamp on the bottom left is called a mosquito clamp. The larger ones are called Burkitts, often used when somebody will call Burkitt and then will hand that instrument to you. On the left is another clamp that's similar to a Burkitt, but it's not curved. It's called a cryle or a straight clamp, and we don't often use those other than to secure tags of swabs and so on. And then the scissors, you get two types. You get a scissor, a tissue scissor called a Mackendorf, or a stitch scissor. So don't cut tissues with a stitch scissor. Okay, you will damage the tissues and make life difficult for yourself. So, general tips during surgery. I'm sure most of you have been in theatre before. The anaesthetist will be at the head end of the table, and there will be a screen between them and you, an operative field. And jokingly, we call that the blood-brain barrier. Generally, we think the brains are at the bottom end of the drape, but they tend to disagree. That drape should not obscure the patient's vitals. You need to keep an eye on what your patient's doing. There's no blood pressure, and your anaesthetist is not very communicative. You need to know about it. The lead surgeons stand on the right side of the table. Every now and then you have a left-handed surgeon who does not. Most left-handed surgeons are trained to operate on the right side of the table, but every now and then you will have a left-handed surgeon standing on the left. So you as the assistant will generally stand on the left side of the bed. The scrub nurse will stand on the left side of the table. Some surgeons prefer to have them on the same side as they are. So during a liver transplant, my scrub nurse will stand on my side of the table to handle across from the operating table, especially big, heavy patients. And then remember to make good notes on the operation performed if you were the lead surgeon. In the ward, you must see your patient at least twice a day and always before you leave for home. Okay. Hand over any issues to the person on call on paper, in writing. Listen to your patients. They are as entitled to develop a new problem as any patient presenting in the emergency department. Okay. Listen to your nursing staff. If they come to you with a problem, remember they see much more of the patient than you and often spot deterioration in the patient best. Listen to the family, especially a mother or a father in the pediatric ward. A parent knows their child best. Remember to communicate with each family and each patient on the progress of the patient, especially the critically ill patient or if you've operated on someone that day. Make a phone call and update that family. Communication is key. The vast majority of medical litigation is not because you've made an honest mistake, but because there's poor communication around the event and negligence in rescuing the situation. So always remember that. Just a note on interacting with other specialists. There is a natural tendency for each specialist to think that they feel the superior to all others. Okay. Know that each clinician that you work with has trained very hard and sacrificed much to be where they are and is very likely to know something that you don't. You will need a friend in each field to ensure good outcomes for your patient. And don't perpetuate the cycle of speaking ill of other disciplines when they are not there to defend themselves. Stereotypes exist for a reason, okay? But each doctor remains a human being with similar needs to your own. Everyone just wants to get their patient through, wants to get home to their families, and are trying to cope with sleep deprivation, training, and stress. If a colleague is a real problem, and some of them will be, rather escalate the matter in private. So here's a few core knowledge things that you will need to be pretty well versed in order to pass any sort of general surgery exam. And if in doubt where to start when you're studying general surgery syllabus, it's focused on common things, the emergencies and the malignancies. Okay. Those past couple of questions always are around resuscitation of the shock patient. You will need to know your trauma of the abdomen, chest, head and neck, vascular and orthopedic. Okay. In vascular, again, the emergencies would include the abdominal aortic aneurysm and the threatened limb. If you don't know those things, it's difficult to pass you. Another emergency, the acute abdomen. You need to know about perforated hollow viscus, ischemic bowel, appendicitis, hernias and their complications, cholecystitis and gallstone disease, and pancreatitis. All of those things can give you an acute abdomen. And often oral exam will start with your patient has got a rigid abdomen. What do you do next? And then the cancers. You must know about the common cancers: breast, colon, melanoma, thyroid, pancreatic malignancy, and esophageal malignancy. Some common radiological problems. I'm more than going to give another talk on all the radiology that you need to know. These are just a few examples of the type of pictures that they will give you during the exam. You need to recognize esophageal cancer. That's the picture on the left, first picture. Achalasia, or next to that, gastric outlet obstruction and our hiatus hernia. You will need to recognize small bowel obstruction. You see in the right upper side that is small bowel obstruction with air fluid levels, and then pneumoperitoneum, that's flicked on the bottom left. You can see free air under the diaphragm, and the picture next to it is an abscess in the liver. Then you need to recognize large bowel obstruction and all the signs related to that, and we can have a talk on that and what you should recognize at a later stage. Another thing to recognize, diverticular disease. You can see those little bubbly bits on the perimenoma, and breast cancer. So, just to end off, transplantation is the love of my life, and William James said, is life worth living? And he said it all depends on the liver, and I tend to agree with that. Just bear in mind that during your career you will deal with a patient who will require an organ transplant, or one who has had an organ transplant, or a patient that could be an organ donor. And looking out and looking after potential organ donors are a critical component of your journey as a clinician. And I like this quote by UNOS, the United Network of Organ Sharing States, who says, "Without the organ donor, there's no story, no hope, and no transplant. But when there is an organ donor, life springs from death, sorrow turns to hope, and a terrible loss becomes a gift." So remember, once you've lost and the road is ended for the patient is brain dead, you can still make a massive difference to other people. So please refer organ donors. What is the future of general surgery? It is blindingly bright. Okay. Super specialization is going to happen. But what about the rise of the generalist? Having people who knows a broad range of pathology is still crucial, especially in the more rural parts of our continent. Robotics and remote surgery is on the rise. Telemedicine, personalized medicine, CRISPR and gene editing is going to change the face of medicine as we know it within our lifetimes. Xenotransplantation is hugely exciting, transplanting organs from animals into humans. And then machine perfusion and autotransplantation. But remember, first do no harm. Whatever you do, don't harm the patient. Some personal considerations. By far the biggest challenge of your life will be to balance the needs of your family with that of your patients. And surgery will take its toll on the strongest of partnerships. Keep your partner and your children involved and informed on what is going on in your life. They are part of your team. Never waste time at work, not a minute. That is precious time away from your family, time that you could be studying. You've all seen this, I'm sure, and whether you be a general surgeon or not. General surgery is found there at the bottom, and generally you need to not like children, not like sleep, not have much of a social life. But I must say that stereotype is kind of changing. So in conclusion, general surgery is a wide, challenging field. To become a good surgeon will take up most of your life. The road is riddled with hardships and the most direct ways of stalling deaths and relieving suffering. Many patients are ungrateful, it's true, but most will bring more to your life than you bring to theirs. And as a last point, most of you will end up having children, and your children, are very forgiving for your work ethic and what your job requires, but only up to a point. So prioritize your family. They will grow old with you, not your patients or your colleagues. And this guy said, pay mind to your own life, your own health, and your wholeness. A bleeding is more help to anyone if it leads to death. And that's the end of my story. Thank you so much to everyone listening. Sorry that was longer than I anticipated. You guys probably need to run off to a lecture. But if anyone wants to stay for a question, you're more than welcome.
Thank you so much, Doctor. That was really an excellent talk and really very enjoyable. I apologize for the technical difficulties.
I look myself out, actually. I do that sometimes.
Yeah. Thank you so much, Doctor. If anybody has a question, you're more than welcome to send it in the chat box, or you can just raise your hand and then unmute yourself and ask your question. Okay, so we'll just give about a minute to 2 minutes for that. Okay, Doctor, so we have a question in the chat box. So Karen asked, why did you choose transplant surgery?
It is a very broad field with a lot of things, a lot of ability, a lot of expertise. Top being able to do one of the most complicated surgeries that you can do on the sickest patients that you can have. So we end up doing massive operations on a critically ill patient that nobody else wants to touch. And on top of that, you do that after taking an organ out of a dead person. So it's pretty sci-fi. And I must admit, once you've gained the skills to take an organ out of it, a patient, a brain dead patient, and you see it work in a living patient that would have died, it's hugely empowering. And especially living donor transplantation, where a lot of parents donate to their children. You have a dying child that you will not see Christmas, who then has a perfectly healthy donor sitting next to them, and having the skill to take out a portion of liver or a kidney from that willing donor and then save that child or adult's life. It's a very worthwhile endeavour, full of hardship and sacrifice for sure. But there are few areas in medicine which will give you as big a high or a kick as that, I must say.
Thank you so much, Doctor. So just someone asked if the slides will be available anywhere after the session. Would Doctor mind sharing the slides with us?
Sure.
And then you can just share it with the students.
Yeah. And Alicia, you can decide what you would need based on the audience and what sort of academic content they would need, and then we can do specific focus specifically. Especially, I know the radiology used to be very stressful for the students going for exams. You can see a lot of it, and we can go through that, whatever you prefer, as required.
Thank you so much, Doctor.
Remember, there's a program where we are trying to get some students to come and see a transplant. I'm sure they should probably tell you a little bit more about it. And when we transplant patients, we're keen on exposing you guys a little bit. The Wits students do come, and their registrars get exposure. But I remember from being at Pretoria, I never saw a liver transplant. I saw a kidney, but not a liver. So that's something that we're trying to get off the ground as well.
Thank you, Doctor. CSSS has been advertising the shadow program, so everybody can just go and have a look at our social media accounts, and then they'll get all of the information there. We're very excited, about it. So we have another question, Doctor. So let me just see. So Robin asked if you work with humanitarian organizations. And also if children can donate to parents.
Right, so I work closely with Bowel, which is an NGO, we try and get a kind of awareness out there to South Africans on organ transplantation and donation. In terms of humanitarian outreaches, I'm not involved at the moment. I'd be very keen to get involved in these sort of outreaches to patients. There must be, if you consider that transplantation is only done in Egypt and then us living donor transplants, then you imagine now the whole African continent not having access to transplantation. So getting involved in that sort of thing would be very cool. In terms of donating to an adult, only children or patients that are over the age of 18 can consent to an organ donation, but certainly adults. Children do donate livers and kidneys to their parents all the time. Yeah.
Thank you, Doctor. That's very interesting. I also wondered about that specific question. Then I have another question over here. So is it possible for surgeons in South Africa to do an audit of their patient outcomes, even if it is not required by law, and do they necessarily have the competence to do so?
Well, that's a good question. I think if you read international literature, let's say you're a person who does a lot of laparoscopic cholecystectomies or mastectomies or whatever you choose to do, or you're a trauma surgeon, read the international literature. People publish their outcomes all the time. And if your rate of cutting off bile ducts is more than what is the international literature, then you should get help. Let someone come and train you, and even just doing the numbers, just writing down how many you've done, for what sort of indications, what is your mortality rate, what are your complication rates, and then showing that to a senior surgeon is more than enough. It's just about that accountability of, am I doing the right thing and where can I improve to keep you out of trouble and to protect your patients. It's really a worthwhile exercise.
That's very good advice, Doctor. I sincerely hope that everybody that becomes a surgeon here one day will follow that.
It's not pleasant. I'm telling you, we all make mistakes and bad things happen all the time. But if you don't learn from it, it's for nothing. That's the worst outcome of not knowing what you did and what you could do better. So don't berate yourself for making mistakes. You will. That's unfortunately, and our job is of such a nature that patients suffer when we make mistakes, and that's something that you will live with. But if you learn from it, you can provide better and better service.
Thank you, Doctor. Doctor, how long are you available for questions?
I'm available in another 10 minutes.
Okay, thank you, Doctor. So we have another question. Another question over here, Doctor. So given the amount of resources required for surgery, are surgical procedures completely impossible in resource-poor settings, even if it's an emergency? So basically, what are the minimum requirements for a surgical procedure?
Right, so there are areas in the world where you are 300-400 kilometers away from obtaining surgery. We know that. But getting an emergency procedure, getting an emergency dealt with, is a human right. That is something that every human being should have access to. So you need very little, to be honest. You need, there are places in the world where caesarean sections are performed with the surgeon doing the spinal, monitoring the patient, doing the caesarean with the nurse helping him, and getting that baby out there. The basics that you would be sterility. You need sterile instruments, you need sterile drugs, and for that you just need an autoclave machine. There you get basic ones out there. Wash your instruments, autoclave them, and basic suturing material. One good set, the one that I showed you there, will get you through 90% of procedures. If you're not going to do a liver transplant, in the bush, you don't need fancy energy devices at all. You need sterility, a few good basic surgical instruments, good lighting, a nurse, and then preferably someone that can anesthetize the patient. So there are units who literally set up a theatre in a container, a shipping container. They drop that container off somewhere and they provide surgery to local people, especially in the war zones. They set these things up overnight. You don't need a lot in there. You can do a lot of good, definitely.
That's very interesting, Doctor. That you only need so little. So we have one final question so far. So what's the best word of advice you've ever received on your journey through medicine?
I think the point about your children is very important. It took me a long time to understand that, because surgery will take everything if you're allowed to. And especially if you're a good surgeon, you will give everything to your patients. But in the end, you cannot be a good surgeon if your children and your partners neglect it. You will be unhappy and miserable. So somehow you need to create a balance. I know it sounds weak and old-fashioned, but it really is so true. Children and your partner do not need loads of time, they need quality time. Often you take your worst personality home. When you're fatigued, you've struggled the whole day with dying patients, you've lost possibly a patient, you're in a miserable mood, you don't know what you're doing, why you ever entered the field. You go home and then your partner gets the worst of you. So don't do that. Your family are with you for life, and you have to invest in them. They will not grow and stay with you. You'll be left alone. You will grow old alone. I see it all the time. So prioritizing the family is it can be done. I did all of my training. I started general surgery training with a 10-month-old baby. So from the word go, I had children involved in it, and they do surgery with you. So make it a team effort. Make them proud of what you do. Tell them what you do, what you've done that day, and they're proud of you as a parent. So that was very important advice. And then to have empathy for patients. To really, all of us will eventually become a patient or have a loved one be a patient. And once you're on the other side and you know how callous some doctors can be, how difficult they are to get a hold of, to communicate with you on what's happening to your loved one, you will get why you need to communicate with your patient. That one phone call makes a huge difference to the family, to know what is going on. What are you doing with my family, and where are we? So communication is critical, and to look after your family for sure. And to being a surgeon does not mean you can't have children. That's rubbish. That's old school thinking. The world has moved on. There are lots of female surgeons who support each other. And there are lots of male surgeons with young children who want to be involved in their children's lives. And together we make a plan to let everyone be with their children. Men also want to be part of their children's lives, obviously. So then they will need the female surgeons to cover. So never feel guilty for taking maternity leave. A male surgeon's wife also took maternity leave when she expected his child. So do what you need to do for your family. Surgery will always wait. It will always be there for you to come back to.
Thank you so much, Doctor. I think that's the first time that a lot of us have ever heard, has ever heard that advice, and it means a lot. So we'll definitely remember that. So we have another question. So regarding skilled individuals, are non-profits the only way of getting them involved in resource-poor settings, particularly regarding surgeons?
Well, there are many organizations that assist in getting involved in rural settings. There are Global Surgery, it's a UK organization that helps get surgery into more rural areas, and then obviously Doctors Without Borders will help you to do that as well. But generally liaising with the local health government, offering your service, and just coordinating the effort will go a long way into getting surgery where it needs to be.
Thank you, Doctor. So we have another question. Okay, so Kaden, yes, the shadowing options are available for students before fourth year as well. So when you go on our social media, you'll see a link for a Google form. So just fill in that Google form, and then you'll be placed on a list, and then we'll select you guys from there. So just I think it's on our Instagram, but also on our Facebook, and then also on the Teacher for Place website. So you'll find the link there. Okay, it's a pleasure. Okay, that seems to be all of the questions, Doctor. Thank you so much for your time and your advice. It was really very helpful.
Okay, great. See you guys soon.
Thank you, Doctor.
Bye.
Bye.
Bye.